My name is Ajay Nooka. I'm an associate professor at the Winship Cancer Institute of Emory University. I'm the chair of the Myeloma Working Group, as well as the medical director for the Winship Research Informatics. I started as a hematology oncology fellow at Emory in 2008, and I graduated in 2011. And 2011, I started as faculty at Emory. So while I was doing my fellowship, we were going through the county hospital, which in Atlanta is a Grady hospital, where there's a huge amount of underserved patient population. And I do have, while I was in the myeloma clinic, there were a lot of people that came in various with various presenting symptoms and signs. This particular patient is somebody that I always remember, because I cannot forget the sight of how he presented. This is a 31-year-old gentleman who was working at McDonald's and comes in unable to walk. So patient was paraplegic when he came in. So what we did was, this was the time where there was still the debate of 2 drugs versus the 3-drug treatments. And this is a young gentleman and in a county hospital. So I was about to graduate at the time. So I knew I was starting as faculty at Emory. This was in the last few weeks. The moment we stabilized him, the patient followed me to come to Emory, and there was a clinical trial that was awaiting him. One of the things that I talked about earlier was he was paraplegic when he came in. With immediate stabilization, he was able to walk in 4 days. So, which led to his improved performance status. So he went on to a good clinical trial, which was evaluating the role of a transplant, which was also called the determination trial here. So the patient went on that specific trial and he went on to the arm that delivered the early transplant, and he did so well. Now he's in his 40s, like, he still continues to come to the clinic. He's in a complete remission, continue to receive the maintenance lenalidomide. This is one of the success stories that I always tell. And this is not the only example that I always have, but there's a ton of examples in the same pathway or managed the same way that still continue to derive these benefits after these long times. But he's a young man who presented really in a bad shape, and immediate stabilization and getting him onto the next tomorrow's regimen today is how I would put it as a clinical trial. And this specific trial was available so that he could take advantage of that. And he continues to work full time, raising his 2 children. And whenever I see him, I have a smile on my face. So that's a good story that I always tell anybody when they're newly diagnosed, so that they know it is not all the gloom and doom. There is good light at the end of the tunnel. So now, why did I give this example, and how often do you see this? If you look at all the clinical trials that have ever been done, all the big data that is put together, you see around 20% of the patients, they follow the tail. The tail is just prolonging and prolonging if you look at any of these survival curves. So those 20% of the people, we always can call them a cure, but all these drugs are only available to us for only 15 years. So these patients are staying in remission for 15 years. So the longer that we follow up and those patients do not relapse, we could be more confident to call them a cure. And this person that I presented now probably falls into one of those people who we can call cure. The key to improving outcomes in myeloma is to increase the proportion of those patients. So that 20% should become 30%, 30% should become 40%, to 100% by the improved access to all these new treatments that we have in hand, that we have in the clinical trials, so that patients can use these drugs so that they can get into that proportion of those patients on the tail.